Thank you for being here because I know that you came directly from the airport. Yes, and I brought the son with me from Rabat, Morocco. It's a great pleasure to be here because this is the hospital where you saved my life because I did had very severe COVID, and knowing that I was coming back here uh, really made me happy because and very emotional. I'll go fast because I have 161 slides, so 20 minutes is going to be a short time. But let me try that. So, pediatrics. Well, pediatrics is about children's words. It's the things that children say or that they don't say. So, let me give you a selection of the consultations that I do see in gastropediatrics. Sometimes we have kids who say that. I'm not going to comment on that. Unfortunately, you don't know what this is about because we don't have time to read that. You don't really decide with who you are going to get married. God decides, and then you see who He gave you. Now, this is of course in Paris in the hospital here. Unfortunately, the interpreter doesn't have the time to read them all. Glance. What's a glance? Well, it's a moron. Daddy, you're still growing. Your head is starting to show under your hair. And then sometimes it's linked to school, and in that case. There is sometimes discomfort. Why does a cat have four legs? Well, the two in the front are for running, and the two at the back for braking. Now, there are things that you need to get right, and there are a certain number of things which which make sense in what children say. Who was the first colon in America? Christopher. When I say I'm beautiful, what time is this? The past. And then I like this one. The kid is asked to find X, so he just circles the X and he says, well, this is where X is. This is mathematics as I like it. Mathematics as I like it. And of course, I like things which are obvious. Sometimes people don't go and see the right specialists. My son is hyperactive. I went to see him. I went to see a pseudo psychiatrist with him instead of pedo psychiatrist. So now, very often you have a child, you wonder what's wrong with them. You can be wrong, of course, but let's look at 4 situations that you cannot miss. The first is this. You see that you have these very hollow ulcerations. You can even see the bone. And that's in infants where there is a big disparity because their general status will be okay, and then you have those lesions. This is the same after 1 week of treatment. You see that it heals very well. It's called ecthyma gangrenosum. And in 2/3 of the cases, it's due to a germ. So you have to take samples and you have to refer these children looking for underlying immune deficit. What is the immune deficit that all doctors know? Well, it's chickenpox. Chickenpox leads to immunodepression. You can have a simple ecthyma, which is impetigo with staph or strepto, and when it's gangrenous during chickenpox, for example, you can have this and look at a severe immune deficit that can be coming from ecthyma. Now, why would they come to see a proctologist? Well, it's because there's something on the buttock and it's a little bit reddish, and so they ask you to see if maybe you could do something about it, knowing that in a lot of people's minds, well, it's an angioma, so it will probably go away after the age of 2, and so basically you have to wait. But when you've got this on the sacrum, it's really important to see what's underneath or what's below it. I heard this story about spina bifida. It's exactly the same thing here, because here you might have angiolipoma, for example, here, and as soon as you have that kind of disease, you might have difficulties which unfortunately will have a negative impact on these kids' life. So when you have an hemangioma on the sacrum after 1 month of age, you need to take a medullary ultrasound and if the kid is older than 1 month, you need to take them to MRI. Sometimes you can see other things. Well, it doesn't matter, but it's important. Why is it important? Well, because you need to see if there is something below, and also you need to treat these hemangiomas. Here, it was published by a dermatologist from Bordeaux. This kid has cardiopathy and hemangioma. When we treated the cardiopathy, we also cured the hemangioma, and we were able to understand that it was really relevant to use propranolol on all hemangiomas. It's really important to be able to treat these children. Then you have guidelines, the IHRS, for example, which allows you to identify whether or not you should use hemangiol on the hemangiomas depending on where they are located. Now, the third situation is this. You have a fissure which is lateral. In pediatrics, that is really important to identify. If this infant has the lateral fissure, I wanted to see the kid again. His parents went away for a year, and then they were repatriated. It's the same kid 1 year later with macrophagic activation syndrome. So just to show you that you have constipation, you have kids who have to push a lot, and when it's lateral, however, you have to look for a disease, an infectious or inflammatory disease, or a trauma. When I say lateral, I mean that, of course, fistulas or fissures, well, in pediatrics, under the age of 15, any fistula or lateral fissures must be explored to look for Crohn's disease, as you can see here with anti-TNF induction. Now, these exuberant lesions sometimes exist in IBD and sometimes under the age of 6. That's the cutoff that I would like to share with you. If it's under the age of 6, it's not going to be chronic. It's not going to be inflammatory bowel disease. It's not going to be Crohn's disease. It's a different entity, which is called very early onset IBD, very early onset IBD, which is due to genetic deficit. So you have several number of publications. Here you can have several diseases, IPEX, etc., granulomatosis, family, Mediterranean fever, etc. So you have to look for that. If the kid is under 6 and he has something that looks like IBD, he has all the IBD symptoms, it means that you need to do a genetic screening and you need to refer them to a gastroenterologist, a pediatrician gastroenterologist, and this must be done urgently. Now, the fourth element on a lateral fissure, this one is a very specific context. It's on the edge of the fissure. As you can see, we found sperm. So that is every time you have a suspect damage, you cannot do anything, I cannot do anything. There is a legal unit in each city, in each big city. You have to call on them. If you are in a situation where you don't know what to do, you can call the CRIP, C-R-I-P. It's a toll-free number, and they will help you because you have identified a case that is concerning, because the kid might have been maltreated. It's sometimes obvious when you've got bruises like this, or when you've got a burn like this with an iron, and then sometimes you also have wrong diagnosis of ill treatment. I was asked here to diagnose this child, and I didn't know what to do because this little girl was very constipated, and I only had the answer 6 months later when the mother told me that she left the child with the grandmother, and the grandmother, she treats constipation by sitting the infant on warm or hot molds, and I don't know if it accelerated transit, but actually what it did was burning the bottom of this little girl, and she also had, it seems, ankle constipation. So this should have been treated probably with a more conventional treatment. Now, if you want to have more information, I refer you to this algorithm that we came up with. It's accessible on the internet. It's called Pediatric Perineal Lesions. It's a step-by-step procedure, and you have these 4 major manifestations. Now, all the rest has to be built step by step. But if you don't build it properly, you will never get to the upper floor. And the road to stool, it's sometimes a long and winding road. And so gastropediatricians or pediatric gastroenterologists sometimes have to find their way around. So I'm going to show you the 9 commands of pediatric proctology. The first one, of course, is to look at the anal margin. You have to do this with the right light, of course. The second is that in infants and newborns, you can have them lying on the side, but in children you have those 2 positions that will allow you to have the best exposure. So it's on the side, as you can see here, with a little pillow under the thigh. And then, of course, you shouldn't see them from too close, otherwise it's going to be a problem. Now, this is a kid who was referred to me for encopresis, and you just had to open the groove to see that there was a fistula. So you really need to have a good sight on the anal margin. Now, in children, it's very difficult because you have to get them to cooperate. And so the question is that of rectal exam. And I'm saying this because a code of ethics was published in 2023. Rectal exam in pediatrics actually gives you no decision-making element. It doesn't help you to identify your diagnosis. So rectal examination has no interest. It is not beneficial for the consultation. So it is enough to have a visual exam of the anal region. I'm saying this because rectal exam, which doesn't work, or which can be a little bit aggressive or perceived as aggressive by the child, might be very badly perceived by the parents. This year we had 3 complaints to the police with pediatricians who carried out rectal exams that were considered to be abusive by the parents. So you have to know that it's something that is complicated. So you need to ask for the child's permission with the parents present, and you ask the parents to look away when it's a teenager, when you perform the rectal exam. And you just need to be able to look at the anal area, rectal area. So, of course, if you ask the child what he thinks about that, this is what he's going to say. And, of course, this has been photoshopped. Right. So you need to carry out a complete clinical examination. If it's a light birth weight, is going to be different. You look at the whole body, you look for canker sores, you look for tumefactions. This kid has proctologic wounds, and I just had to open his mouth and I saw what was in the inside of his cheek. There was also a granuloma that meant Crohn's disease. When you have potentially venereal lesions or damage, you can look at potential sexual abuse. You don't want to be intrusive, of course, but you have situations like this here on the left-hand side where you see syphilis. In that case, there's no possible discussion. On the right-hand side, however, for a very long time, condylomas, HPV condylomas were always of mucosal origin. And it is actually not the case, because you can actually have warts in children that might generate condylomas. So, on the vulva or on the anus, when you have associated malformations, of course, you can have very specific situations. you have to know a little bit of dermatology. Here you have the kid who's itchy, and in that case, you need to use Gogner, and when you have that kind of damage, if you scratch it and it's become like a rash, so if it's urticaria, it can be a situation where the pediatrician proctologist also has to look at skin diseases and know about dermatology. Of course, we don't want to get confused with adult diseases. You have to know that hemorrhoids do not exist in children, and when hemorrhoids appear, they don't have to be operated on. Same for anal fissure. So, as Robert Debré said, the child is not just a miniature adult, it is an adult in the making. And so usually we don't need to go for exploration in these children, because a clinical exam should suffice. So let's try to look at perineal damage, which is very frequent, which you will see as doctors in general and as proctologists in particular. Very often it's children who are very constipated with disabling erythema, as you can see here, with indurations on the edge. Very often you have a little bit of seeping, and you also have damage on the outside of the erythema. In 1/3 of cases you have also lesions on the genitals, and this is typical of a streptococci anitis, which is a very frequent streptococcal perianal infection. It's very, very frequent, and you know that the diagnosis is the same. It's the same streptococcus as the one in strep throat, just one serotype difference. But if you take a sample with a swab, you're going to have a lot of false negatives, because this streptococcal perianal infection is a co-infection of strep and staph. And as you don't know, the staph in the petri dish will actually inhibit the culture of the streptococcus. So you will have a false negative. So what you need to do when you suspect a streptococcal perianal infection is a quick diagnosis test. And in that case, you have to treat it. It's co-infection, so you shouldn't treat with amoxicillin only, but with amoxicillin plus clavulanic acid. Unfortunately, these infections will recur, sometimes in association with skin infections like psoriasis or oxyurosis, as you can see here. There is an abundant literature. So for Streptococcus perianal infection, the diagnosis is TDR. You treat with amoxicillin and clavulanic acid. You have to tell the mom that it will probably recur, and you need to look for an associated disease. Back to the fistulas. In infants, we say that there is probably going to be an abscess. In most cases, we are looking at infants under 6, right, and newborn under 1 year of age. You know, if it's an ordinary fistula, it's called fistula inano. It's typical of this, and if it's ordinary, you just need to come up with a local antiseptic and antibiotic treatment. It is very, very rare to operate on these infants in that kind of situation. If it's a little bit more complex, you can go for Crohn's disease, and Verneuil's disease also exists in children after puberty. Fissures, not much to say, other than it can happen at any moment with, as a rule, are situations which you don't apply local treatment on. For anal fissure, you don't need to apply ointment or cream or anything. Anal fissure is something that you treat only by treating the cause, which is constipation in most cases. Sometimes, if you have a fissure in a very, very young infant, in which case it's more abnormal closure of the perineal groove, sometimes you have a cyst, and you see a lot of a little bit of a cap on the fissure here, and the mother says, "My child has a cap on the anus," and I say, "It's a cap," and she says, "Yes, that's what I'm coming for," and I say, "Yes, you've got the diagnosis right. It's just this little keloid scar, which you have to leave." And sometimes it's big. The mother says, "There was never a fissure, my kid is not constipated," and then you have a kid who is either a teenager or a newborn, in which case it's called a pyramidal protrusion. There's no fissure here. And I will finish with what we discussed before. That is those venous lesions. It's vascular congestion. We call it marginal venous congestion. It's not hemorrhoids. It may bleed, but it never leads to complications. And you can see that it can be very impressive to look at. And thank you for your attention.